When I'm meeting a patient who has just been diagnosed with metastatic lung cancer, I talk with them about the fact that there are really three different strategies for therapy. The standard remains chemotherapy, usually with a platinum doublet, but we're also going to be thinking about whether or not they might be better served by molecularly targeted treatment or by immunotherapy. And the decision between those three strategies really has to do with testing the tumor. So we need to know about PD-L1 level with the 22C3 test to figure out if immunotherapy with pembrolizumab versus the chemotherapy might be better. We also need to get the molecular test results, especially thinking about EGFR, ALK, and ROS, because if we find any of those driver mutations, then going after that will be our first strategy. So those are really the key things that we're thinking about. And then if we decide that they are going to be a candidate for one of those three, then we're thinking, making sure there's no reason they shouldn't get treated with that. So if someone has a bad autoimmune disease, even if they do have a high PD-L1 expression level, we're not going to recommend immune therapy, or there might be reasons that standard chemotherapy wouldn't be appropriate. But excluding those folks, which is a rare percentage, we're going to be focusing on chemotherapy if there's no reason to do anything else, immunotherapy if they have high PD-L1, or molecularly targeted if their tumor has a reasonable molecular target.
So in a patient who has non-squamous non-small cell lung cancer for their frontline treatment, we have to do the genetic profiling. So if they have an EGFR mutation, they get a EGFR TKI as frontline therapy. If they have an ALK translocation, then they would get an appropriate ALK inhibitor. Right now it's crizotinib, but it could potentially be ceritinib or alectinib. For our patients who don't have a mutation that is a driver mutation that we put on a trial, you want to consider giving systemic chemotherapy, or if they have high PD-L1 expression over 50%, then we usually would recommend doing an immunotherapy with pembrolizumab.
There are several goals of treatment in the first-line setting. Often your patients have symptoms, so they feel bad or having trouble breathing, and so one immediate goal is just to relieve symptoms. Can you get disease to respond, to shrink, to ease pain, to improve breathing, sometimes to help them get out of the hospital. So that's a very important goal. We talk a lot about increasing survival, so we do things to try to keep people alive longer, and that's a very important goal. I always tell patients, though, if we're unsuccessful in doing that, if we can at least keep them alive where they're living well, where their symptoms aren't advanced or they've regressed, hopefully we can add life or days to their lives, but at a minimum, if we can at least control symptoms and improve the quality of their life, I think that's a very worthwhile goal. These are all important things to discuss with patients up front, where sometimes they're not sure why we're even doing treatment. I thought I heard lung cancer is not a treatable cancer. And so it's important to express this message that we can get you to feel better, we can make the time you have better for you, and we can extend your life. Those are all important goals that are meaningful for patients and their families.